blood pressure of 210 over 115 with no symptoms. She had no primary. As per program standards, we acted. I called the referral line. An appointment was made with Family Practice Group in Winchester for later in that day. I know this is the way it's supposed to work, but the fact that it really did was impressive. Please extend my thanks to the entire crew. Now, this surgeon, who did not want blood pressures taken in his office, has now become the champion throughout that entire system to get all the specialists on board taking blood pressures in their office. So these 4 drivers of motivation, mastery, autonomy, relatedness, purpose, I think are woven into every successful Measure Up, Pressure Down by the AMGA groups. When we create a deep sense of fulfillment and satisfaction through our efforts, when we can tap into natural passions and drives, and when we can connect, as I said, with not only the minds, but with the hearts of our physicians and our care teams, I'm convinced we'll not only improve blood pressure, but we'll begin to transform healthcare and get better outcomes for all of our patients. So I'd like to thank the Right Care Initiative for inviting the American Medical Group Foundation to present at this year's event, and I hope we'll provide you valuable structure and insight to help each of you address the ambitious goals of Right Care Initiative. So thank you, and with that, I'd like to now turn it over to Kendra, who's going to lead you through some of the findings from the campaign.
Thank you, Jerry, and good morning, everyone. We're excited to be here today to talk about the Measure Up, Pressure Down campaign and some of the activities that we've been embarking on over the last few years of the campaign. First, I thought I would start with just giving a little bit of background about the campaign and how we began on this journey. A few years ago, the American Medical Group Foundation's board came to us and really wanted to launch this multi-year initiative that would address some of the nation's most chronic diseases and really rally our AMGA members together to affect change among their patients. So we took on hypertension as the first disease state that we wanted to address because we saw that there were some significant milestones and activities that we can implement that would affect some quick change in patients across the country. So hypertension became our first campaign, and as Jerry stated, it is a 3-year initiative that will run through 2016. And so Measure Up, Pressure Down began and launched in early November of 2012, and we are halfway through the campaign now, and here are some of the things that we've been working on. So primarily the campaign's goals is to really mobilize the medical groups, AMGA members, to help their patients achieve better hypertension control. And secondly, we wanted to engage the patients in this process too. So it was kind of a twofold goal where we're working with both our medical groups and indirectly through our patients to get to 80% of control by 2016. And to do this, what we've been able to do is develop a host of materials and resources that both our members can use and our patients to really get in control by 2016. As you'll see on the right, these are some of the patient materials that we've developed, different patient handbooks and booklets, tip sheets, things on social media where we're engaging them on a regular basis, as well as our website too, where there's a host of information that both medical providers and patients can go to find resources and tools that they need. The provider toolkit has been our primary resource for our healthcare professionals because it really does create a roadmap of materials and tools and success stories that our groups can use to implement in their own practice groups. We also have a listserv and monthly webinars where our healthcare professionals engage with each other so that they're able to ask questions, they're able to collaborate and work together to address any barriers and any concerns that they may be meeting within their own practices. So the campaign planks is really the framework of the campaign and how these groups are going about getting to goal of 80%. And these really grew out of some best practice and learning collaboratives where on a smaller scale, some of our groups were getting together to address hypertension, maybe 15 to 20 groups. And they identified these 8 evidence-based care processes that were leading to improvement of hypertension within their practice groups. And what we found is that if a group implemented at least one of these 8 campaign planks, that they were guaranteed to show some level of improvement of hypertension within their groups. So as these first 5 you see here, we call these our primary care process planks. And they range from things as directing their care staff and making sure that everyone is trained in giving accurate blood pressure measurement. The second one is in regards to hypertension guidelines and making sure your group sets up some sort of hypertension guideline or algorithm that everybody is following and is a standardized process. The third one is that blood pressure is addressed at each hypertension visit. With your either primary care visit or any time that you're coming for a follow-up treatment, that your blood pressure is being addressed. And then the fourth one is that all patients that are not at goal are, or have a new prescription are seen within 30 days. And then lastly, the fifth one is about patient engagement and making sure that the healthcare provider is putting a self-management plan in place with their patients so that they know the steps to take to get into better control of their own blood pressure. And in no order, you don't have to do these in order. We just ask the group to adopt at least one of these. And then these next 3 are really the value-added ones. So these are kind of what we call our bonus planks, where they require a little bit more infrastructure, sometimes a little bit more staff bandwidth. As you see, the first one is about setting up a registry, which will require a lot more time and commitment to be able to do that. Making sure all team members are trained in blood pressure goals and making sure everyone's on board with that. And then lastly, that all specialists are being involved with the example that Jerry just gave, and the whole care team is being involved in managing blood pressure. And again, we ask that each group at least adopt one of these. Some are adopting 1 or more. Some have tackled all 8. And so they're, of course, seeing some very impressive results if you're taking on more than 1. So next I wanted to do just a quick poll of the audience to see how many campaign planks is your organization or group may be implementing, either none, 1, or 2 or more. Is it polling open? There you go. Okay. There's a few more coming in. All right. And there we go. So good. It looks like most of you are doing at least 2 or more, which also hopefully means that you're participating in the campaign so that we are taking account of that in your efforts in working on the campaign planks. Oops. Next, I wanted to talk about our campaign reach. To date, we have nearly 150 of AMGA medical groups that are participating in the campaign. As you see, the blue dots indicate where we have AMGA groups located across the country, and the red dots indicate those groups that are actually participating in the Measure Up, Pressure Down campaign. So we're happy to have that number and continue to accept more into the campaign at this point as well. And this is just a quick list, a snapshot to see all of the groups that are participating. And collectively, all of these groups deliver care to more than 42 million patients across the country. Here's just a summary of our campaign sponsors. We have 8 campaign sponsors that are currently supporting the campaign. These sponsors provide financial support so that we're able to implement some of the activities, develop resources and materials. I'd like to call out particularly Palo Alto Medical Foundation and Ralph's, who I know in the room today, for your financial support for the campaign. And these sponsors can come in at varying levels of support that really help us achieve our goal of getting to 80%. This next slide shows our campaign partners. We have 13 partners that we work with across the country. These are all like-minded organizations that are working in a similar disease state. They do not provide financial support for the campaign, but they do, however, collaborate with us on materials and resources. They really help us to amplify our reach into the community, get to different areas that we may not be able to touch. As you can see, we work with Million Hearts, American Heart Association, and we really make sure that these relationships are mutually beneficial, so we enter into letters of agreement with each of these entities to make sure that we're meeting common goals and working with these partners. And again, we strategically align and work with these partners and choose them to make sure that we're all working towards the same goal of hypertension improvement. And next, I wanted to just give a quick summary of campaign impact and how we're moving the needle. Primary to our campaign, we wanted to make sure that we build in some sort of evaluation and data measurement so that at the end of this, in 2016, we would be able to see whether we actually moved the needle and got to that 80%. So this part of our campaign really differentiates us from others and distinguishes us because at the end of this, we'll be able to see if we've moved the needle and by how much, and also what are the care processes that led to these better outcomes for our groups. And as you can see, some of the early results in the first quarter of 2014, we really looked at 3 different areas of prevalence, control rates, and improvement rates. And the average prevalence rate of our groups is now at 29%. And just so you know, this was 79 groups that we looked at data for, that reported their data for the campaign for the first quarter. The average control rate of those 79 groups was at 69%, which, again, our overall goal is 80%, and this shows 69% control. So you can see that we're getting there, but we still have a little bit more work to do. And then the average improvement rate from quarter 1 of 2013 to quarter 1 of 2014 is at 2% among those groups, which means, in general, that 205,000 patients now have improved high blood pressure detection and control thanks to the Measure Up, Pressure Down efforts and their groups for participating and adopting at least one of the campaign planks that I spoke about. Thank you. Here's just a few success stories of our groups that are participating, and this is just a quick snapshot. The groups that are here with us today will go into more detail of what they're actually doing, but as you can see, it shows the number of planks that some of these groups are adopting, the percentage that they're increasing, and we have more stories like this that we love sharing and posting on our website and really promoting the work that our group is doing, because without them, we wouldn't be able to really get to this goal, and we want to make sure that we're helping them in any way do that. And lastly, I wanted to talk about an event that we did this year called the National Day of Action Roll Up Your Sleeves. This was the inaugural event for the campaign that we did on May 15th during National High Blood Pressure Education Month, where we asked all of our supporters and participants across the country to take one action to improve high blood pressure control. An action could have been anything from conducting a blood pressure screening to posting on social media, to posting a newsletter. So it really ranged from what the activities were. And as you can see, here are some of the images from around the country of groups that participated on May 15th on that day. And as a result, we were able to have a total impact of 57.4 million Americans across the country that were in some way touched with a hypertension control message on that day. And here's just some of the national recognition that the campaign has been receiving over the last year. We were awarded as the 2013 award winner of National Forum's Heart Healthy Stroke Free Award. We were mentioned in Forbes as well as on local news media. And 3 of our groups were recognized as 2013 Million Hearts Hypertension Control Champions. So we are very excited about that acknowledgement and recognition that our groups have been receiving for their participation in the campaign. And that is it. And I will now turn it over to Dr. John Cutterback, who is our Chief Medical Informatics Officer at AMGA, who will discuss hypertension data.
Well, thanks, Kendra. Let's see. I want to tell you a little bit about a subset of AMGA members who have trusted us with their detailed data, and we are using the data together with their collaboration to help improve outcomes for their patients. AMGA has been working on a model for shared learning for more than 2 decades. Groups would come together, share what's not working, which requires a lot of trust among the groups, and what they can learn from each other. What slowed things down, though, was the fact that they needed some data to understand who was doing really well and where the problems were. And that was always a slow part of the process because people would have to go back and get data out of their systems and bring them for comparison. So the idea of ANSETA, which is the name of our collaborative, was to start with data because AMGA members have been in the forefront in terms of adopting EHRs. We had 90% adoption 6 or 7 years ago. So the idea was to develop a collaboration with a company called Humedica, which is a clinical informatics firm, startup in Boston, to actually extract the data and allow us to do comparative evaluation at a very detailed level. So that's the ANSETA Collaborative. It's named for an obscure Roman goddess of healing, who I think was also involved with snakes and maybe snake oil. So we try to think, not to think too hard about that. I'll tell you a little bit about the use of comparative clinical analytics and then also our experience with Measure Up, Pressure Down and the detailed, using the detailed data. And we, as I said, we have about 38 groups now. Some are still in implementation, so you will not see, we're still growing pretty rapidly. So you won't see all of the 38 groups here, but you'll see a good representative sample. So the idea of our collaborative is simply to use comparative data together with collaborative shared learning and create performance improvement. And the whole idea of our little apples to apples logo is that we want to be able to use truly comparable data. So anyway, best performance, then learn from those people how they did that. The rest of the story. So a little bit about what Humedica does. They actually extract the data from the EHRs. They take outbound claims data as well. They do mapping and validation and normalization of the data. They actually apply natural language processing as well because there are some very important things, not for hypertension necessarily, but say for example understanding congestive heart failure. The left ventricular ejection fraction is a really important parameter, and it is almost never in a structured field in an EHR. It's usually in an echo report or a cath report. So the ability to read those reports and extract those data is really kind of important. Humedica then builds predictive models and specific models for the conditions, the drugs that are used to treat each condition, and they make the data available to the groups through a platform called Optum One. And the reason it's called Optum One is Humedica is now a part of Optum, but I'll tell you a little bit more about that in a minute. So just as an example of the cleaning and normalizing and validation of data, and you will recognize this if you actually work with practical data, this is from the pharmacy master of a single medical group, which has a very good, very well run, very well managed Epic system. And this is the 52 ways that lisinopril is entered in that system. And so the one thing you might suspect is that there are a number of different ways to misspell lisinopril. So creativity is encouraged here, clearly. But the interesting thing is that the people who are empowered to manage the pharmacy master in this really good medical group don't notice that there are separate fields for dosage form and strength. This is just the field for the name of the drug. So this is what the normalization and mapping allows us to deal with. And it's really important because if you just did simple queries, you would miss a lot of the important data. So AMGA Jerry's told you about our foundation. We have ANSETA, which is a separate component of AMGA, but part and parcel of AMGA for all practical purposes. Humedica is our partner. They were acquired by Optum a little over a year and a half ago. They do the data factory work and make the data available to the groups. And then we also have the opportunity to work with Optum Labs, which is a center for collaboration. And I won't talk much about that for right now, but that is an important part of our work. Here are our current ANSETA participants, and we have a couple of them here, Brown and Toland and Scripps, and you will hear from Colorado Springs Health Partners in just a minute. But one of the things that's really good about this is we have a combination of very large groups and very small groups, and it turns out there's no real monopoly on innovation. Everybody has got something that they're doing at the point of care that other people can learn from, and they're very willing to share. So here's our map. Same AMGA members, but in this case, the blue ones are the ones who are participating in the ANSETA Collaborative. And a little bit about Humedica's disease models. We built models for these chronic conditions. You see we have currently about 6 million patients with hypertension. And for those conditions, evidence of disease, turns out there are a fair number of patients who have chronic diseases that you may miss if you're just looking at diagnosis codes, or even if you look at problem lists in the EHR. So one of the big advantages is to be able to look at laboratory data and clinical observations, things like blood pressure, pulmonary function tests, BMIs, that sort of thing. And then we impute data, sociodemographics, because those are really important aspects of care, and certainly things that are important in improvement. We also are working on things like panel size for primary care physicians, patterns of opioid prescribing, lots of things people are interested in doing with the data. But back to hypertension for now. One of the things that I think is really interesting is the range of prevalence of chronic conditions. You can see here that we have, and each column is a medical group, and the rows are the different chronic conditions for which we have built models. So you can see the top row is diabetes, and the patients in blue are the ones who have diabetes. So there's a twofold difference across these two groups in the proportion of their adult population who have diabetes. Twofold difference here on hypertension, twofold difference on dyslipidemia, more than a fourfold difference in terms of the prevalence of heart failure. So one of the things that's really important as we look at comparing the performance of these groups is these differences in their patient population. These are some box and whisker plots. We're basically looking, each one is sort of a vertical distribution, and the box is the middle half of the population in terms of median household income, imputed from at the zip code level from census data. But you can see that we have 4 groups over here on the left, 4 medical groups, where the median household income, maybe it's 5, I guess, who are above $50,000. Over here, we have 9 groups where the median, for 75% of their patients. So 75%, here's the middle half, and then the top half is, or the top quarter is above that. That's what the box and whisker plots mean. And you can see over here there are 9 groups where 75% of their population is below $50,000, and then some others that are in between. So again, very different burdens of socioeconomic issues to deal with in these different populations, something we have to consider as we're doing comparative analyses. We thought it would be pretty simple because, after all, there is a standardized measure for blood pressure control, NQF-18, which is used in meaningful use, it's used in PQRS, it's used in the ACO measures. Turns out it's much harder than you think, unless you've actually been doing it, which I know many of you have been, to actually get standardized versions of these measures from different groups. But we won't spend a lot of time on exactly how we do that. What we are doing for Measure Up, Pressure Down is for the Anseta groups, we're actually reporting for them. And one of the things you'll see is that the missing blood pressures, patients who have a visit but do not have a blood pressure recorded, is something we see since we have all of their EHR data and we know who's had visits and who's diagnosed with hypertension and fits into the denominator. We don't necessarily know that for other groups, and who are reporting simply their populations, their denominators, and then their numerators. But technically, if the patient had a visit and has not had and does not have blood pressure recorded, that's counted as out of control. Okay. So what happens when the guidelines change partway during your campaign? So the guidelines change for people who are over 60 without diabetes or chronic kidney disease. Instead of 140 over 90, it's 150. So 61% of the patients with hypertension are 60 or more, 34% without diabetes or CKD. So this could have a huge impact on your campaign and on what you would consider a reasonable control rate for your population, unless you happen to have the actual blood pressure readings for these people and knew that only 4% of them have systolic blood pressures between 140 and 149. So that's one of the real benefits of having this kind of data, is that you can look at these sorts of things and determine the impact of something like this. So here are blood pressure control rates by medical group. You see the people who have missing data up here in the gray. And you can see that we have one group who's already over the 80%, and then the 3%, 4%, or 5% of patients who were not in control under the original guidelines would be considered in control under the new guidelines. And it's an opportunity for us to say, you know, you've got 25% or so of your patients who are out of control under any guideline. So let's not quibble over the folks in the middle. Let's focus on the people who have a lot to gain by a little reduction in a very high blood pressure that they currently have. Thought it might also be interesting along that line to look at the stage 1 and stage 2 hypertension, which again you can do if you have the ability to look at the individual blood pressures. So back to the campaign. You remember our first process plank is direct care staff are trained in accurate blood pressure measurement. A very important part of this, we asked people as they entered the campaign which of the planks they had already implemented. And 74% said that they had implemented the first plank. And it's interesting to actually look at what people are recording as systolic blood pressures. Since this is a physiologic quantity, you would expect a nice smooth distribution, and not necessarily symmetric, but at least a smooth distribution. And that's essentially what you're seeing in these three medical groups whose systolic blood pressures are combined. You can see there are a few odd numbers here. About the only way you get odd numbers is if people are actually using automated cuffs, because most everybody rounds to 2 millimeters of mercury when they're reading from a blood pressure cuff. But some people round to 10 millimeters of mercury. We have two medical groups where a lot of people are a multiple of 10. So we got kind of interested in this and started looking at a fairly typical medical group. This is not an extreme. You can see they do have a lot of folks, a lot of their sites who are using automated cuffs. You get the odd numbers. But what we did was look at the last digit of the blood pressure they're writing down. Now, that should be, 1/10 for each digit, or if you're rounding to 2 millimeters, it should be 20% for each digit. So in this case, it's 32.5%, and then you can see, and you sort of see how the color maps go. And the reason we turned this into a vertical distribution is so that we could compare different medical groups and different provider teams. So here, for example, you see Group A among a whole range of medical groups. So there's their 32.5% zeros, 36% zeros for the diastolic readings. But you see we have a couple of groups here where 50% are rounded to a zero. We also now are going to look at a group that seems to be doing pretty well overall, 24%, 29%. So this is Group 1. Now we will look, though, here's group 1 as a whole, systolic blood pressure here. These are individual provider teams within group 1. And each of these teams has at least 50 patients with hypertension, and you'll see that you've got folks who are recording 54, 56, 71% with a 0 as the terminal digit. So a lot of rounding going on, and even in a group which doesn't appear to be doing much rounding. And you can see here, well, maybe that doesn't matter if your blood pressure is 110/60. But these are folks whose blood pressures are 134/84 or higher, and you can still see there's a lot of rounding. Note, too, there's a little purple here. Those are the 8s, the people who are just at 138. There seems to be a few more of those than you might otherwise expect from a distribution. But anyway, not a whole lot. Really, there's less rounding down than we would have expected. But at any rate, that's what we're seeing. Here's an example of a before and after, sending those data around, actually the data being used by medical groups. And you can see one clinic in one group where the physician said, we're not going to tolerate that, we're going to fix that problem. So that's what they did. Another thing you can do if you have lots of data is people say, well, I don't like my patients being judged just on the basis of the last blood pressure. I'd like to look at the last 2 out of 3 or the last 3 out of 5. So we're able to go back and see the proportion of patients who are in control, and then the patients who are always out of control or would be in control if we looked at 2 out of 3, 3 out of 5. And you can see it's about 8% more that are in control overall, but it turns out that it's about the same 8% for everybody. So it's one of these things, let's not worry about the details, let's look at the patients who are out of control under any way of looking at it and see where we can have improvement. Here's hypertension control by quarter, and you can see we have seasonality. You can see that the warmer months, you get better blood pressure control. And yes, it does matter by geography as well. And so here is what this looks like for lots of different medical groups whose data we have. And you can see that there is one medical group here, and you will hear from them in a moment, Colorado Springs Health Partners, who everybody else is just sort of going through the seasonal process, and you can see they are managing to improve their control rate every quarter, even as that's going on. So anyway, kind of an interesting way of looking for best performers that we can learn from, and that very soon you will be learning from. And Kendra has already shown you this. I'm the data guy, so I'll just comment that this is the proportion of the total patient population. We learned from Kaiser that it's really important to understand prevalence of hypertension as it's reflected in your diagnoses to make sure that you're detecting hypertension appropriately in your population. So we've got some kind of squirrely numbers up here for very high prevalence, so we may not be getting the full population basis for the reporting for some of these, but that's why you have the data. These are the ANSETA groups combined with the others who are reporting through a portal that we have for the people who are just reporting their own performance. And just one last point is you realize there are so many variables here that it really is important to be able to understand how all of those variables work. Rather than just descriptive analysis, to use the methodologies that are being developed that give us the way to draw causal inferences, sound, solid causal inferences from observational data, rather than just association, that it's really a causation. And here's an example of the association between persistent blood pressure over 140/90 with a 30 or 50% decline in GFR over the space of a year. Now, this is only about 5.5%, 6% of the population overall. 4% have 30% decline in GFR, 1% have about 50% decline, but you can see that being under 65 and having diabetes doubles your risk of a 30% decline, triples your risk of a